everybody. It's a great pleasure to have today Dr. Alice Domar. She is the Executive Director of the Domar Center for Mind and Body Health. She is the Director of Integrated Care at Boston IVF and an Associate Professor of Obstetric, Gynecology, and Reproductive Biology at the Harvard Medical School. She is a past chair of the Mental Health Professional Group of the ASRM. Her presentation today is about stress in ART, physical, psychological symptoms, patient retention, and outcome. Please.
Thank you very much. I appreciate the opportunity to talk about a topic which is near and dear to my heart. I've been researching this topic for about 33 years, and I've been seeing patients. So I have a disclosure. I'm the co-owner and the co-founder of Ferticom, Fertistrong, and Elise Health Apps. So there's been a lot of research in the last 20 years or so which documents the massive impact that infertility has on the emotional well-being of both women and men. I'm sorry, there's been much more research on women, but as I'll talk, we actually now have data on some men. And trying unsuccessfully to conceive really takes a huge psychological toll. And for patients, they try on their own for a year or 2 or 3. They then proceed to see an infertility specialist. They get a workup. And as they go through the process of trying on their own and then getting the courage to see a physician and having the workup, a lot of them are already highly distressed before they even see a physician, and then treatment makes them more and more stressed. And what we do know is that stress is actually highly associated with treatment termination. So it's one of the leading causes why patients drop out of treatment. But I'll explain the data that's been around for about 20 years now. There is also some data that stress, emotional distress, may be associated with lower pregnancy rates from treatment. However, there's a fair amount of data now that shows that a lot of different psychological interventions that have been shown to decrease distress may also in turn increase retention to treatment as well as pregnancy rates. And I'll explain further. So what a lot of people have been wondering, what actually is the psychological profile of the average infertility patient? And up until this study that came out in 2004, all of the research was done where we would hand patients a questionnaire and a paper and pen, or pencil or a pen, and ask them to fill it out. And by doing that, you often get underreporting because patients feel very strongly that they want to present to their physician, a normal psychological profile. And so until 2004, I think we were underreporting how distressed our patients were. But the study that was published in 2004, they assessed women who had never seen an infertility doctor. And they met with a psychiatrist before their first visit, and 40% had a psychiatric disorder. So the most common was anxiety, followed by depression. And the women who had a diagnosis did not differ in terms of age, education, income, or years of infertility. But if you think about this, 40% of the patients that we see are distressed and or anxious before they see any of us. And I can tell you, going through a workup and going through treatment is not going to help them feel psychologically healthier. So one thing that I worry a lot about as a psychologist is this issue of suicide. And I didn't think that suicide was an issue for infertility patients. And so I was giving a talk a number of years ago at a clinic in the US. And the clinic asked me if suicide was an issue with infertility. And I said, no, I think actually the fact that someone's trying to get pregnant means they have hope for the future. But this clinic had actually just had a suicide. So I actually looked at the data. And in fact, close to 10% of women who are going through IVF actually have suicidal ideation, and some of them have done suicidal attempts. And the women who are the highest risk are ones who had no children or had fewer children and were more depressed. So this means that we really need to take the emotional health of our patients very seriously. A more recent study out of California, as I said, we're now including men in research, and they looked at 352 women and 274 men. 56% of the women and 32% of the men scored in the clinical range for depression. This is the cutoff. These people have a clinical depression. And 76% of the women and 61% of the men had an anxiety disorder. So this just shows in this tidbit of information the psychological impact of infertility for the first time on not just women, but also on their partners. So why should we care about patient distress? You know, we're putting patients through very complex treatment protocols. Why should we care about patient distress? Well, one of the reasons is that depression is a big risk factor for treatment discontinuation. And so if you look at the data on which patients are most likely to drop out of treatment, these are insured patients: depression, poor prognosis, a longer duration of infertility, and a higher parity. Now, none of us can change the prognosis. We can't change their time of trying, and we can't change their parity. We can, however, treat their depression and their distress. So that's one thing that we can control. So until 2004, you know, people thought that patient dropout was only attributed to money and physician recommendation. So until 2004, we really thought that patients would keep on going through treatment unless they ran out of money or they lost insurance coverage, or their physician said to them, look, I'm really sorry, your prognosis is just too poor. You need to either be child-free or do egg donation or do adoption. And that's what we thought was the reason people were dropping out. But we were actually wrong. There was a series of papers in 2004 which actually showed that distress was the top reason why insured patients. So for uninsured patients who don't have the financial resources to pay for treatment, cost is the most common reason for treatment termination. So if people can't afford it, they can't borrow the money, they don't have insurance, yes, that is the reason they drop out. However, for insured patients and for those with financial assets, according to every study done worldwide, the most common reason for treatment termination is the emotional burden of treatment. And as I mentioned before, this research shows the depression level of the female partner prior to treatment is the strongest predictor of treatment termination, stronger than age. And so this means that we really need to start paying attention to the emotional health of our patients prior to treating them. Because if they start treatment when they're highly distressed, they are far more likely to drop out. And in fact, in another study, they showed the depression level, the higher the depression level of the female partner, the more likely they were to drop out of treatment after only one cycle. So what contributes to this burden? Why are our patients so burdened? They feel embarrassed, they feel shameful, they feel very lonely. They don't feel there's anyone they can talk to. I mean, pretty much by definition, their mother didn't go through infertility. They're seeing their siblings and their friends and their neighbors and their coworkers get pregnant. They feel very different and isolated from everyone who can simply have sex and get pregnant, and their friends who get pregnant by accident. They don't understand the complexities of the treatment regime. And what feels so comfortable to us, and the things that we talk about, you know, ICSI and IUI and PGT and all these things that feel so comfortable for us, it's a language that feels very foreign to our patients, and they don't understand it. Waiting. I have patients tell me that waiting is the hardest part. And now during the COVID epidemic, you know, that's a whole nother topic. But for patients to have to wait, you know, they wait to see a physician for the first time. They wait to have tests. Then they have to wait to see the physician again to get the test results. Then they have to wait to start treatment. Then they have to wait the 2-week wait until they find out if they're pregnant. And then if they get pregnant, they have to wait to see if their beta goes up, and they have to wait for the ultrasound. And what a lot of my patients are telling me now, the waiting is really the hardest part. Patients have a really hard time balancing, you know, psyching themselves up and being hopeful versus too much optimism, because they're afraid if they're too optimistic, they will crash and burn if their cycle doesn't work. Patients are very stressed by missing work. Research now is showing it's one of the top stressors with infertility. It has a huge negative impact on sexuality and intimacy. You know, they're told when and when they should and shouldn't have sex. Women tend to only want to have sex mid-cycle. Men feel the only reason their wife is willing to make love to them is to get their sperm. So it has a huge impact on their sex life. Family and friends don't understand. They may make hurtful comments. They may not mean to make hurtful comments, but they do. Massive disappointments of failed cycles. A lot of marital disagreements. Maybe the woman wants to keep on cycling and the man doesn't want to, or vice versa. And as I said, there's this every single month, there's a roller coaster ride of getting excited for the first 2 weeks and very nervous the second 2 weeks, and then disappointed if the cycle doesn't work. What contributes to the physical burden? We don't talk about that very often. People don't like blood tests. They don't like getting stuck all the time. Vaginal ultrasounds are uncomfortable, and they can be traumatic for patients who have a history of sexual abuse. And we have to remember at least a third of our patients have a history of sexual abuse. And so vaginal ultrasounds can feel very, very scary. Injections, some patients have 1, 2, 3 injections a day. Egg retrievals. For those of us who work in the medical field, it doesn't feel scary, but a lot of our patients have never had an IV started. They've never had anesthesia. They've never walked into what looks like a recovery room. And so it's very frightening for them for the first time to be a patient. A lot of complaints from patients about progesterone delivery. Injections hurt. Patients don't like having the vaginal suppositories because it interferes with intercourse. Getting to the clinic first thing in the morning for blood work and ultrasound, or coming, during the day for physician visits, and interferes with their work. And what does a patient do if a meeting is scheduled at the exact same time they have an IUI? Or what if their boss tells them to go on a work trip when they've already started an IVF cycle? There are side effects of medications. There's timing of injections. I had a patient once who had bought tickets to see a U2 concert like a year before the concert. It happened to be, of course, the night of her trigger shot, and she had to take her trigger shot in a porta potty. So one of those little portable, and it was awful for her. And of course, then we talk to patients about changing their lifestyle habits. We're telling them to decrease caffeine and alcohol, and to stop smoking, and to lose weight, and to eat more healthfully. That can cause stress. So what about ART causes stress? So I've been doing a lot of research at Boston IVF for about 5 years now on why women drop out of treatment. And we did a study on 268 women who had insurance coverage for 6 IVF cycles, but dropped out of treatment. And we asked them why they dropped out of treatment. And just like all the other research, the top reason was it was too stressful. And we said, okay, what could we have done? Why are you in that? What was the stress? And they said they felt they had given IVF their best chance. They felt they were too anxious or depressed to continue, and they felt it was affecting their relationship with their partner too much. So our patients are very clear about why they're dropping out of treatment. It's just too much for them emotionally. So what are we doing to decrease the emotional burden? I would ask all of you, what are we doing to help our patients cope with the psychological, the emotional side effects of treatment? And we're not doing enough. In that study that I reported that Lori Pash did at University of California at San Francisco, of the patients who reported those significant anxiety and depressive symptoms, 21% of women and 11% of men reported they had received any mental health services. And about a quarter said that information was made available to them about mental health services. So here we have a population of patients who are highly distressed and have really significant symptoms of anxiety and depression. And we're not offering them mental health services. They're not even made known to the patients. So let's look at another aspect of stress and an ART outcome. A lot of patients, if you ask patients, most of them will believe or will tell you that stress has an impact on treatment success. And a lot of patients, if their cycle doesn't work, will actually say, I had a fight with my mother-in-law, or work was really stressful. The research is less definitive. There have been studies, which I'll show you, that show that stress does have an impact, and there have been studies that show that stress does not have an impact. However, the research, according to a Cochrane review, the research is really not very good. The collection of the pre-cycle baseline psychological data has literally ranged from collecting it 2 months before cycle start to the day of cycle start. 2 months before a cycle start, the psychological state of a patient really has nothing to do with how she's doing 2 months later. A lot of ART patients, when they finally get to IVF, have really high levels of pre-cycle optimism. And so if you assess a patient at the beginning of a cycle, that might not assess her true psychological state. And as I mentioned before, many infertility patients will not report honestly their true level of psychological distress. And in fact, we did a study at Boston IVF where we wanted to assess patients' depression levels. And so we actually had one of our physicians mail a depression scale to their patients so that he could see how depressed they were before they started treatment. And 76% of the patients refused to complete the depression scale. When we asked them why, they said they didn't want their physician to know how depressed they were. So I think it's really tough to actually adequately assess the true relationship between stress and ART outcome. The four most recent reports, one in 2018 was a meta-analysis, and they found that stress had no impact. In 2017, a study on 22 studies on 4,000 patients showed that stress and anxiety were associated, as was another study they did in 2018. And the most recent study shows that stress was related to pregnancy and birth. However, a Cochrane review in 2016 showed no relationship between distress and ART outcome. So I think we just don't know. And, I just published an opinion piece in Fertility and Sterility saying, I think we need to stop arguing about whether or not distress impacts ART outcome, because I don't think we're ever going to really know the answer because of all the variables. And I think we really need to stop arguing and just agree that our patients are distressed, and we need to focus more on patient-centered care. How can we decrease the emotional burden? Our patients actually prioritize patient-centered care over pregnancy rates. There was a big study out of Europe where they asked patients and they asked REIs, what's more important to you? And patients actually prioritize patient-centered care over pregnancy rates. And their physicians thought that patients would prioritize pregnancy rates. And so we need to start listening to our patients. Our patients want to be cared for. So in one of our studies, we asked our patients, what could have made their care less stressful? And what could we have done to have kept you in treatment? And these were the most common suggestions. They wanted more convenient office hours. The second one was easy and immediate access to a mental health professional. They wanted more access to their physician. They wanted more convenient locations. And then look at the next three. They wanted evening peer support groups. They wanted written stress management information, and they wanted stress reduction classes. So if you look at the top 7 answers, 4 of them had to do with their emotional distress. These patients are crying for us to do something to help them feel less distressed. So what is the efficacy of psychological interventions to decrease distress and potentially increase pregnancy rates? So there have been 4 recent meta-analyses. The first by Fredrickson included 6 studies on pregnancy and 20 on psychological state. And they found, in fact, it was highly significant, that psychological interventions were associated with higher pregnancy rates and lower rates of distress. A year later, Chow included 12 studies, and they found that psychological interventions were associated with less distress, better marital relationships, and higher pregnancy rates. Chu in 2017 found that psychological interventions were associated with decreases in anxiety, but not depression or distress. And the most recent study, meta-analysis on 11 studies, showed that psychological interventions were associated with decreases in depression, anxiety, and distress, and improvements in quality of life. So there have been, dozens of studies now and 4 recent meta-analyses, which have all shown that psychological interventions decrease distress, decrease the emotional burden of care, and several of the meta-analyses showed increases in pregnancy rates. So the research, if you look at all the research on different psychological interventions, it's concluded that the most effective intervention have a cognitive behavioral focus. And I'm a cognitive behavioral therapist. And what we do with cognitive behavior therapy is we help patients challenge and reframe their automatic negative thought patterns. And so if you ask our patients, what are the thoughts that go through your head? They'll all say the same thing. I'll never have a baby. The infertility is my fault. I don't deserve to have a baby. My partner's going to leave me for a fertile woman. I shouldn't have drunk so much in college. I shouldn't have smoked in college. I'm too fat. I'm too thin. I'm not exercising enough. I'm exercising too much. And what you do with CBT is you help them get to a more neutral state. So for example, they may start with, I'll never have a baby, and they may get to, I'm doing everything I can to have a child. So CBT is highly effective with lots of different patient populations. It's clearly effective in working with our patient population. So several years ago, I collaborated with Jackie Boyven, who's in Wales, looking to see if we could intervene using a psychological intervention to decrease dropout rates. And we recruited 166 women at Boston IVF who were about to begin their very first IVF cycle. And we randomized them, and half of them received a packet, which was cognitive coping, so a little bit of that cognitive behavioral therapy, and relaxation. So they got a relaxation CD. So the intervention patients got cognitive coping and relaxation versus patients who did not get that packet. And we simply left them alone for 12 months. We didn't check in. We didn't ask them if they're using the coping. We just left them alone for 12 months. And we found was the patients who got that packet in the mail, their rate of dropout was 67% lower than the patients who didn't get the packet. So a packet that cost us $12 was associated with a 67% decrease in dropouts. In addition, the patients who got the packet were more able to positively cope. They had a better quality of life, and they had significantly less anxiety. However, there were no differences in pregnancy rates between the two groups. But we showed if you literally mail patients a stress management packet, they are going to be less anxious, they're going to cope better, and they're much less likely to drop out of treatment. I have been working with a colleague of mine, Liz Grill at Cornell, to see if we can use mobile applications, so apps, phone apps, to add CBT. And so she and I have come up with two apps. The Ferticom is for women and Fertistrong is for men. What we did was, and both of us have been working with patients for a long time, we came up with the 50 situations which our patients find the most stressful, such as getting that phone call saying you're not pregnant, or being at a family dinner and having your little sister announcing she's pregnant, or sitting in the waiting room waiting to see the doctor. So what we did was we took those 50 life situations, and each one has 6 potential things to decrease stress. So for example, there might be social solutions, which are scripts they can use when people say things that are insensitive, or they're cognitive, which is that cognitive behavior, ways if someone says something insensitive, how they can think in a different way. And each app contains 10 pre-recorded relaxation experiential exercises in my voice. So these are the two apps. Fertistrong is for men, as I said. Ferticom is for women. They've been out. The female app has been out for 3 years. The male app has been out for 2 years. We were not able to do any research on the female app because it was literally released. It was built and developed about 2 days before it was released. But with the male app, we had about 6 weeks between when it was built and when it was released. And so we were able to do a very small 1-month randomized controlled trial on the male app. And we recruited 38 men, and half of them, literally 19 of them, got the Fertistrong app, half did not. And there were actually, even though there was only 19 men in each group, we actually had several significant improvements in the intervention group. And on all testing, on all the psychological tests we use, the intervention group trended to less distress. So this is preliminary evidence that mobile apps actually do have some efficacy with our patient population. And I also collaborated with a graduate student, Jessica Clifton, where she took the 10-week in-person mind-body program for infertility, and she converted it into an online intervention. And she recruited 71 women with infertility who had infertility, and she randomized them. So half of them had access to the 10-week mind-body program, and half were on a waitlist control group. And what she found was women in the intervention group relative to the waitlist control group had extremely significant reductions in distress. And if you look at these p-values, considering there are about 35 women in each group, the p-values are exceptionally strong. And the odds of becoming pregnant was 4.4 times higher for the intervention group as compared to the waitlist group. And they also got pregnant sooner. So this is preliminary evidence that, combined with the app research, that patients don't have to literally come in and attend a group or see a therapist in person, that there are things like mobile apps and online programs which may be highly efficacious to decrease burden and maybe increase pregnancy rates in our patient population. So as I mentioned before, I'm the chief psychologist at Boston IVF, and we have added a lot of different services to Boston IVF in an effort to decrease distress and improve patient retention. So we have the Mind-Body program for infertility, which is a 10-session group treatment program. I actually have trained mental health professionals around the world and in many countries and across the US how to offer this program. It includes that cognitive behavior therapy, relaxation training, group support. We also give patients information on which complementary and alternative treatments are safe and effective versus which are not. And we talk a lot about lifestyle habits and which ones patients should try to change. We also offer individual and couples counseling by PhD psychologists. Every patient who's had an unsuccessful cycle is entitled to a free 30-minute counseling session with one of the psychologists, where what we do is we talk about what coping skills they use during that cycle, and then we talk and teach them new ones they can use for future cycles. We do crisis intervention. So in fact, the Domar Center now was remodeled about 2 years ago, and they added ultrasound into the integrative care center. So the prenatal ultrasounds are done literally 3 to 6 feet from the psychologist. So any patient who has had no heartbeat in a prenatal scan gets to see one of the psychologists within the hour. We go into the PACU if a patient has had disappointing egg retrieval or fertilization results. The psychologists see patients on the hour for 45 minutes. So all of us are free for the last 15 minutes. And so we can see patients in crisis within the hour. We also offer acupuncture 7 days a week, 365 days a year. We have nutritional counseling 2 days a week, and we have yoga by appointment. In 2019, we had over 8,000 patients visit the Domar Center, which is the integrative care center. We also did a study whether or not the Domar Center adds to patient volume, and so we did a recent survey, and we found that 7.3% of new Boston IVF patients came to Boston IVF because it had an integrative care center and because it has a holistic approach. And so if you do the data, the potential for an integrative care center to bring in about $3.6 million a year in new patient revenue. And that does not include the potential for the integrative care services to decrease patient dropouts. We have not done that research yet, but I do know that in the Mind-Body program, patients have not dropped out of treatment. So what are our recommendations? How can we decrease patient distress and increase patient retention? So one idea is to screen patients before they begin treatment and refer these at-risk patients to a mental health professional. Because if you can reduce their distress, reduce their depression prior to treatment, you have a greater chance of them not dropping out. You want to create educational materials to prepare them. Patients want to know what to expect. You want to give them easily accessible psychological counseling and coping interventions. Have a mental health professional on site or one that you can easily refer patients to. You want to integrate treatment protocols and medication delivery systems which are associated with less distress. Patients are very clear about which protocols and which medication delivery systems are harder for them. New research has shown that ensuring the partner is included and involved reduces the distress of the female partner. You want to integrate psychological support into daily care of patients, and you want to support nurses and teach them things that they can use to help patients feel less distress. And you want to create ways to support patients who experience negative cycles. If patients are supported and taught coping skills after a negative cycle, they are more likely to return to treatment. So in conclusion, infertility patients of both genders report high levels of anxiety and depression. The most common reason for insured patients to drop out of treatment is distress. Distress might be associated with lower pregnancy rates with ART. Providing patients with specific stress management skills, specifically cognitive behavior therapy, is cost effective and is associated with very significant decreases in dropout rates. And providing on-site integrated care services increases patients' emotional support and may very well have a highly positive impact on clinic volume. Thank you very much.
Thank you, Alice, for an excellent talk. I think it's very important that the medical team will understand what's patient going through in terms of stress. Obviously, it will help.
How can I get out of the slideshow so I can see you. Hold on. Ah, there you are. Okay. I can't move it. It's not, oh, there we go. Oh, okay. Hi.
Okay, so let's repeat it. I think it's very interesting lecture, actually super one. And I think it's very important that the medical team will understand what's patient going through in terms of stress, so they will be able to approach them in maybe a better way to relieve the stress during the treatment. I want you to comment, if possible, just with few sentences, what do you think about going on patients today while we are locked down, there are no treatment, infertility clinic around the world are closed, patients staying at home, some of them are becoming older within time, some of the patients need treatment because of cancer, fertility preservation due to cancer. So what do you think? How can we deal with these patients when they come back into treatment?
So, you know, COVID-19, the pandemic, has a lot of repercussions around the world, obviously. And I think we do have to pay attention to the psychological impact of these cycles being canceled. And there was a study that came out yesterday in fertility and sterility, and the results are incredible. It was out of Columbia University, and they surveyed patients to ask them, in effect, what do you think about your cycle being canceled? And 22% rated it having their cycle canceled because of COVID-19. 22% said it was equivalent to the loss of a child. And that's just extraordinary to me. 85% of the respondents found their cycle being delayed or canceled to be moderately or extremely upsetting. And I think we really need to pay attention to this data. I agree with you. We have some patients who are urgent. I mean, I personally have a 16-year-old. I mean, a patient of mine who is 16 with premature ovarian failure. And, her physician has told her and me that if she can't cycle quickly, she's probably never going to have a genetic child. And you're right. We have cancer patients. We have patients over the age of 40. We have patients with low ovarian reserve. The patients personally that I have been seeing are having an incredibly difficult time coping with their cancellation or delay of cycles. And, for them, it has been catastrophic. And so, I've been working for the last, 3 or 4 weeks, giving webinars. I've created a lot of physical, documents on how patients can cope. It's been distributed worldwide, as far as I know. There's a 7.5-page document for patients, one for staff. Liz Grill, who's the chief psychologist at Cornell's Medical Center, she and I have been doing a lot of webinars. We're trying to support patients. We're trying to teach them skills which they can use to lessen their anxiety as they wait, hopefully, for the guidelines to be lifted and patients being able to cycle again. The one thing I have been telling my patients, the patients that are mine personally and the ones where I've been giving webinars is, okay, if your cycle is going to be, delayed 1, 2, 3 months, maybe you could use this opportunity of 1, 2, or 3 months, and hopefully not more than that, to make yourself healthier. This is a really good time to look at your lifestyle habits. And, if you're drinking a lot of alcohol, or you're drinking a lot of caffeine, or you're smoking cigarettes, you're stuck at home. Maybe this is a good time to very slowly start taking baby steps to decrease, your alcohol, caffeine, or nicotine intake. This is a great time to try to eat as healthfully as you can. If you are able to exercise, this is a good time to integrate an exercise routine. So, a lot of people do have more free time right now. They're saving on commuting time. A lot of people are out of work. This is a time to sort of check in and see what your health habits are and which ones you do feel comfortable changing to make yourself as healthy as possible when you do get back into treatment. This is also a really good time to start learning stress and relaxation techniques. And so to start a meditation practice daily, to start using yoga. I mean, there are all these beautiful 30-day yoga programs that are now free online. I've basically told every one of my patients for the last month, why don't you do one of these 30-day yoga programs? And I think if we can get our patients to change their lifestyle habits for this period of time and to focus on learning relaxation and stress management strategies, it'll make the waiting time easier, and they will actually be healthier when they start their cycle. And presumably they'll actually have a better chance of getting pregnant.
Thank you very much. Thank you very much again for these very exciting lectures. I hope that soon we'll be behind this worldwide health crisis and we'll be back into normal daily work. And keep safe. Thank you again.
Thank you very much. Please keep safe and healthy, everybody.
Thank you.